Hello, this is Dr. Lucy Lane. I am a radiologist at Northwestern Medical Center and I'm specializing in breast radiology. Welcome to today's Lunch and Learn. We're going to talk about screening and diagnostic imaging in unique populations today. So, we're going to cover what is breast screening and diagnostic imaging, screening during pregnancy and lactation, screening in the transgender population, and screening for high risk men. So, screening and diagnostic imaging. When someone comes in for screening mammography, we do two views. One is called a CC view, and one is called an MLO view. And that basically means top to bottom or side to side, how we're looking at the breast. Um, when someone comes in for diagnostic imaging, they either have a clinical concern, so there's some sort of mass or pain, or a finding which is seen on a screening mammogram, and then they're returning to take a look at that. And when someone comes in for diagnostic imaging, we usually will do special views, including compression or magnification views to look at calcifications. We can do targeted ultrasound, MRI, or sometimes contrast enhanced mammography, though we're not currently doing that at our institution. The National Cancer Institute shows that the US breast cancer death rate in women has dropped 40% since 1980s, which is when breast cancer screening became more widespread. Approximately 75% of breast cancers occur in women who do not have any family history or high risk. And so this is why we have a screening program. One in six cancers occur in women ages 40 to 49, and the lifetime risk of breast cancer for women is estimated at 13%, which is approximately one in eight women will get breast cancer. So, those sort of statistics all go into our ACR or American College of Radiology guidelines, which recommend yearly screening breast mammograms starting at age 40, have a risk evaluation by age 30 years of age. And then, if high risk, generally we stagger a screening mammogram and an MRI every 6 months. So, we're going to cover imaging in pregnant and lactating women. So, I think it's very important that everyone knows that mammography is not contraindicated during pregnancy or lactation. There's no significant radiation dose that would cause a problem for the growing fetus, and no problem for a lactating breast in the course of someone's lifetime. Ultrasound is always safe during pregnancy and lactation as well. In general, if someone comes in with a palpable mass during pregnancy, then we'll start with an ultrasound. Magnetic resonance imaging is not safe during pregnancy, but can be performed during lactation. So, gadolinium contrast is not safe for the developing fetus. However, it does not, the amount that goes into breast milk is not enough to make any kind of biological difference for a baby. And so, there's no real need to pump and dump. You just can have your MRI and then go back to normal life, um, and know that you're getting the screening that you need. So the ACR states that both mammogram and ipsilateral axillary ultrasound are indicated for staging pregnancy-associated breast cancer. And when we say that, so it would mean you get a mammogram of the breast if a breast cancer is suspected. And then we also take a look at the armpit. That's what the axilla is, with ultrasound. So, in patients that are high risk and pregnant, we recommend a clinical breast exam every 6 to 12 months. Of course, if it's every 12 months, probably you won't be pregnant at that point. They recommend annual mammography, so don't skip your annual mammogram, come and have it. And then you can consider whole breast ultrasound as a supplemental tool because you cannot have MRI during pregnancy with gadolinium contrast. And then after, you can resume annual breast MRI when you're lactating. So this is a mammogram in a pregnant patient, and you can see how dense it is. And that's as the breast tissue is getting more and more developed, and the lactiferous ducts are getting more and more developed. We see this increase in density across the board, which does make seeing through this difficult. However, we really still have a very high rate of sensitivity for any kind of breast cancer in a pregnant patient with mammography. In addition, on ultrasound, this is what we see naturally. So you get the proliferation of ducts into the tissue. You get a little bit more blood flow to the tissue. And then this last image here, you can see how the ducts are becoming dilated. This is a fun MRI, which shows an MRI A is showing us before the patient had her baby. And you can see this is the background parenchyma, which we talk about. We talk about something called background parenchymal enhancement. So basically, it's not very bright on A. And then you move forward to B and C, and you see how dense all of this tissue is and how bright it is. And that's during lactation. And so that's showing the increased metabolism of the tissue and just the natural changes that happen during lactation. Pregnancy associated breast cancer is its own thing, and that is a breast cancer that's diagnosed in pregnancy, up to 12 months postpartum, and during lactation. It's the most common invasive cancer diagnosed during pregnancy. And then cancers in pregnant and lactating patients are more likely to be diagnosed at a later stage than cancers in non pregnant patients. And part of the reason for that we think is because of a delay in getting evaluated. And so we definitely don't want to have that delay. And that's why I want to talk about this today. Generally, pregnancy associated breast cancer presents as a painless mass, but it can present as unilateral breast enlargement, skin thickening, bloody nipple discharge, axillary adenopathy, which just means that your lymph nodes in your armpit are enlarged, or milk rejection. Most are high grade invasive ductal carcinomas, ERPR negative. Many benign conditions that are seen more in pregnant and lactating women include lactating adenomas, galactoceles, mastitis, and abscess, and we'll go over that a bit today. So this is a mammogram in a 40-year-old woman, 2 months postpartum, with a palpable retroareolar lump, and she presents for diagnostic mammogram. So you can see that triangle is what we call a marker. We put that on the skin, and the circle is around the mass that we see there. And this, we can see it a little bit better on our magnification. On ultrasound, targeted to the area of palpable concern, we see that there is a mass, and you can see it there in the center. It has blood flow. It's a little bit heterogeneous, and it has really nice margins, very smooth on the edges. We biopsied this, and it turned out to be a lactating adenoma. So this is a very well differentiated benign breast tumor in pregnant, lactating, or postpartum women. They're usually soft, palpable, mobile mass. They enlarge rapidly during the first and second trimesters, so they're hormonally mediated. And they're generally very nicely circumscribed, meaning the borders are nice. On mammography, they can have somewhat indistinct margins. And the majority of these actually regress or go away after you discontinue breastfeeding. If it's very large, you can use a medication called bromocriptine, and there's no associated risk of malignancy in this. Now, at the incision site, this is kind of one of the feared complications of doing a biopsy, and that is a milk duct fistula. So you see this ropey thing here with internal schmutz, as you might say, or echogenic debris, and that corresponds with the milk that is coming through the tract that was used to do the biopsy. Here's another mammogram of, you see, this is a palpable concern. It has the triangular marker there. And we can see that that's in the lower, mid, central left breast. And here we go. So now we're looking at this mass, and we can see that what I would say is that it's generally cystic. It has some sort of debris inside it. Um, and this corresponds with exactly what we were seeing on the mammogram. And this turned out to be a galactocele. So, galactoceles are again painless, mobile mass in a lactating woman, and it's secondary to a blocked duct. So basically, you get a collection of milk, and because of that, you get a different views. They can look very different on ultrasound, depending on the age of the milk. And kind of how it's coagulated. Generally, you'll get a fat fluid level. Um, and you won't have any flow on color Doppler. So there's no blood flow to this, which helps you understand that it's just a collection of milk and not a mass. And the majority of these actually regress after breastfeeding as well, like the lactating adenoma. Now, this is an example in a patient who had progressive redness of the skin, pain, and ulceration of another feared complication, which is an infected abscess. Here's another example of a mass in a pregnant patient who came in. You can see the mammogram has her area of concern, and then on ultrasound, we see it very well. The mammogram is trying to show, I think, that there's a few calcifications associated with this. And this corresponded with a pregnancy associated breast cancer on mammography and ultrasound. Um, and pregnancy associated breast cancers, the thing to know about this is really that they can present like this, where they look fairly, they have nice borders. They look like something that we would generally classify as a benign mass. But in general, we recommend sampling these masses during pregnancy, specifically because pregnancy associated breast cancers are highly aggressive but can look very benign. So basically, while if someone came in and they weren't in this pregnant or lactating group, we wouldn't necessarily have to biopsy this. We would follow it in 6 months. In this particular population, even with the risk of those complications that I showed you, that would still be recommended because this has the tendency to look like a benign finding. Next, I'm going to cover imaging in the transgender population. So in the US, the transgender population is estimated at 0.6% of adults, or 1.4 million people. And this is likely an underestimate because it just depends on who is reporting. Um, a transgender person experiences discordance between the natal sex and the innate sense of femininity or masculinity. A transgender woman is a natal male with a feminine gender identity. A transgender man is a natal female with masculine gender identity. A non transgender person, described as cisgender, experiences concordance between their natal sex and gender identity. Currently, there are no evidence-based screening guidelines for the transgender population. A transgender woman may choose to have hormonal supplementation in addition to implants. Maximal breast growth is usually 2 to 3 years following the beginning of hormonal treatment. And in general, as a radiologist, something I have to keep in mind is my language. And so when somebody is on hormonal therapy and they come in for a mammogram, in general, we are encouraged not to use the term gynecomastia, though I will go over that later, but maybe just conspicuous nipple areolar complex, because you end up having this dense breast tissue, which you can see in the image below, and that's the natural progression of hormonal therapy and treatment. Um, the histology of the breast tissue is similar to natal females with acinar and lobular formation, which is different than just general gynecomastia. And they can therefore have cysts, fibroadenomas, and clear nipple discharge in general associated with these therapies. Um, there is In a recent study, it was a Dutch study, they looked at 2,260 transgender women and found that there was an increased incidence of breast cancer compared to natal males. But the risk is still not as high as natal females. The main caveat was that the risk seemed to increase after 5 years of treatment. So that plays into the recommendations right now for the American College of Radiology for screening. So, suggested screening guidelines in transgender women is if you are on hormone therapy for greater than 5 years, and you have risk factors. So, risk factors generally are things like BRCA or other genetic factors, or if you have, there are things called like the Tyre-Crucic. There are ways of scoring a patient and telling them their risk, and that looks at your family history and all kinds of things. So if you have an increased risk factor and you've taken hormone therapy for greater than 5 years, then we actually recommend that you screen as a natal female per the ACR. If you don't have any risk factors, then really it's discussion with your patient. Obviously, we're going to do diagnostic imaging anytime anyone has a concern, um, but not necessarily falling into the screening population. And again, more research is continuing to be done on this to try and figure out exactly what the risk is. Again, imaging in the transgender man. So currently, there are no evidence based screening guidelines. A transgender man may choose to have androgen therapy in addition to bilateral mastectomies. The masculinizing effect typically takes effect over about 2 years. All benign and malignant breast conditions in the natal female can be found in transgender men. And if the patients undergo mastectomy, post surgical complications, including hematoma, seroma, and abscess, may also be evaluated by breast imaging. Um, in general, the screening guidelines in a transgender man, if you've had or if they've had reduction mammoplasty, or no mastectomy, then basically you should be screened as a natal female. If you have had a bilateral mastectomy, then annual chest wall and axillary physical exam is recommended. And this is an example of a 22-year-old transgender woman after 7 years of hormonal therapy who has very dense tissue and some cysts. And that's the cyst is this oval object here that's very dark. That's what fluid looks like on ultrasound. And then this is a 26-year-old transgender woman on hormonal therapy with a palpable concern. And this is the normal expected appearance of what we call flame shaped tissue behind the nipple as at the very beginning of hormonal therapy. This on mammogram, you can see that there is a mass here in the outer upper breast. And this is just showing differences in density in breast tissue. And this is what it looked like on the ultrasound. And again, that corresponds with a cyst. So, breast imaging in men, the lifetime risk of breast cancer in men is approximately 1 in 800. If they're high risk, so BRCA2, CHEK2, PALB2, these are all genetic risk factors, it can increase their risk to 8 to 12%, which is basically to the risk of a woman. So it kind of, there are ways of looking at this, but it can increase their risk significantly. So if a man has had a previous breast cancer, the risk is 52 to 93-fold increased risk of subsequent breast cancer compared to their average risk counterpart, which is pretty significant. The National Cancer Institute database shows a higher breast cancer mortality in men across all disease stages, with a 19% higher fully adjusted overall mortality in men compared to women. And really, it's probably because men tend to present at a later stage of disease. So, diagnostic mammography is the mainstay of male breast imaging. It's highly sensitive and specific, with a near 100% negative predictive value, which just means that if we say that there's nothing going on, more likely than not, we're correct. Um, if mammogram is consistent with gynecomastia or pseudogynecomastia, we don't have to do an ultrasound. And mammography alone is diagnostic for gynecomastia in 90% of cases. Then, if we're not sure, we can do a targeted ultrasound. And gynecomastia is something that happens to male breast tissue. Again, it's hormonally mediated. It can be due to things like steroid use, different medications, and it can also be due to liver dysfunction. So, it's important to make note of it, and if someone has this, to talk with their primary care physician about what they can do about it, because the nodular and dendritic phases are possibly reversible. But once you get to diffuse glandular phase and you can see how dense this is, it's not reversible at that point. And then in general, what we're looking for is nodular is a little fan-shaped density. It can often be uncomfortable for the patient or painful, and we see people for lumps. Same thing, so the dendritic phase, you get that branching patterns of duct, sort of flame shape, and that's the chronic fibrotic phase of ductal and stromal proliferation. And then diffuse glandular is you just have an increase in breast density and enlargement. Male breast cancer, it's predominantly ductal in origin because they don't have, in general, the lobular elements that women have in order to breastfeed. DCIS is the most common precursor, and in general, mammography is fantastic for DCIS because if there are associated microcalcifications, we will see them, and we only see those on mammography. So that's something I get asked a lot. Why do I need a mammogram versus ultrasound? So, mammogram is really amazing for seeing strange things like pulling of the tissue that an early or infiltrative cancer will show, or calcifications and really tiny ones. And we don't see those with ultrasound. They're overwhelmingly luminal type cancers and hormone receptor positive, which is usually super responsive and sort of the best kind of breast cancer. But again, men tend to present, I think, later. So they have poorer outcomes. And gynecomastia is by far the most common cause of breast symptoms in men. Right now, the ACR recommends evaluation in the symptomatic male breast. So basically, we'll do diagnostic imaging anytime. If you're less than 25, then we start with ultrasound. If you're greater than 25, then we'll generally start with a mammogram and then go on to ultrasound, just because it's so helpful for gynecomastia. Now, if you have an increased risk of breast cancer, the ASCO recommends ipsilateral annual mammogram in men with a history of breast cancer treated with lumpectomy, regardless of genetic predisposition, because of that increased risk. And then contralateral annual mammogram may be offered if they have a history of breast cancer and a genetic predisposition. And then for male BRCA carriers or men at the higher risk with the other genetic markers I listed before, we recommend an annual clinical breast exam starting at 35, and then they can consider annual mammogram in men with gynecomastia starting at age 50 or 10 years before the earliest known male breast cancer in the family. So whichever comes first. In summary, transgender patients should be included in screening after 5 years of hormone replacement therapy if they have associated risk factors. High-risk men may be screened if they are greater than 50 and/or have prior breast cancer with risk factors. Breast cancer screening with mammogram and ultrasound can be performed throughout pregnancy. Breast cancer screening during lactation can include mammography, ultrasound, and MRI. And nursing or pumping before imaging may help decrease breast density and increase patient comfort, though it's not necessary. And then diagnostic imaging can be performed for any of these populations at any time. For men less than 25, we start with ultrasound. Otherwise, we start with mammography. For women who are pregnant, we start with ultrasound. Otherwise, we start with mammography and no MRI in pregnant women. Thank you so much for your time today. I hope that this was interesting and helpful. And if you have any questions, feel free to email me. Thank you so much. This was at the European Society of Breast Imaging meeting this summer. And here are some of my references. Thank you.